Good morning. This is the Safe House Project webinar series. We are a national anti-trafficking organization that works to serve survivors and help uplift and train boots on the ground organizations that are serving survivors through various means. My name is Alia Azariah. I am a survivor myself, and I'm also director of aftercare for Safe House Project. And one of the things that I get to do to benefit the industry is bring this webinar series to you all. We're in their third year of the webinar series. I appreciate you all joining. This is going to be, if you're somebody who joins our webinar series regularly, this is going to be a little bit different. I have really been wanting to ensure that I am bringing you the industry, all of the information that's available. And some of those things are incredible presentations that partners have put together. And so I'm going to be not as involved in this webinar in the facilitation. I'm here to just do some housekeeping with you all, help facilitate question and answer, but really going to give to the experts to be able to explain this information to you and the time and the research that they have put into this topic. And I'm going to go ahead and hand it over to our incredible presenters, Laura Lederer and Heidi Olson, to talk a little bit about why they started this, what the catalyst was for this research, and what they found. So I appreciate you all being here. Thanks, Heidi.
Yeah, absolutely. Thanks so much for having us. And thank you to everyone who's here. I'm seeing all these incredible people who are here attending, and it's an honor. I'm going to share my screen. You guys can see our PowerPoint. Hey, all right. So my background is I'm a forensic nurse. I wear lots of different hats right now, but one of the roles that I'm doing is that I'm working with a Medicaid health plan called CareSource as a consultant. And I'll get more into that in just a second. But when I hear the word Medicaid, I immediately am like, oh, this is so boring. I think I just instantly tune out. This is boring. I don't care. Nobody cares about this. It's just a bunch of jargon that we don't understand. As a nurse, that's my perspective, right? It's just blah, insurance stuff, boring. But the reality is, as I have been working more in the Medicaid world, there's actually an incredible opportunity for us when we're talking about trafficking victims and survivors to really be able to fund and provide trafficking specific services through Medicaid. And it's an avenue that I think historically we've never thought about before. So this will not be a boring presentation. I think it'll actually be really helpful. And so I'm going to walk through just the beginning of what exactly is Medicaid? How do we use this to our advantage when we're trying to provide services? And then Laura will take over this really incredible research that she just finished. We are very thankful that you're here, and we'll have discussion at the end. So if you have questions, we'd love to hear from you, or even just thoughts around all of this. So what we know about Medicaid is that many people who are considered a vulnerable population have Medicaid as their insurance provider, if they have insurance at all, including trafficking victims and survivors. And I think historically, we've never thought about how we could use Medicaid to help fund services that trafficking survivors need. And so that's what we're looking at in this. So we'll start from the beginning. Like I said, Medicaid is confusing. I think it can be a snooze fest when we're talking about a topic. And it's really complicated. There's so many layers. So I'm going to try and break it down in a way that it's, oh, okay, I get it. I understand what this is for. First of all, I will just step back and say, if you ask the average person, what's the difference between Medicaid and Medicare? Even healthcare worker, like myself 5 years ago, I could not have told you what the difference was. I don't know. It has something to do with the federal government, right? So let's break it down. So what Medicaid is, essentially it was created to be an insurance provider for several different groups of people. So one, for kids who are in state custody. So when we're talking about kids in foster care or kids where they're a ward of the state, they're automatically going to have Medicaid as their insurance provider in every state. Then we also know with kids and adults who are low income, who are struggling with poverty, they're also going to qualify for Medicaid, depending. There's a threshold you can look up in each state. You can't make more than this certain amount of money to qualify. So low income adults and kids are going to qualify for Medicaid, and then adults who qualify for disability. So again, vulnerable populations, people who otherwise cannot access or afford private insurance, Medicaid was created for these populations. So that's in essence what Medicaid is. Medicare is a completely different insurance program for older adults, and we're not talking about that at all. So we're just focusing on Medicaid, kind of kids, adults who qualify, and adults who qualify for disability. All 50 states have Medicaid health plans. So wherever you live, there is Medicaid there. And if you're in the United States, and what happens is the federal government basically budgets a certain amount of money for Medicaid. And they say, okay, we're going to allocate a certain amount to each state. Now, it's going to vary state to state. So not all 50 states get an equal amount of money, because we have to think about population. We have to think about who qualifies, income, all of those different things. So one state may get more money for Medicaid versus another state, just based on, again, who's qualifying, what the population is, vulnerabilities, things like that. Federal government takes the money, they give it to each state, decides who those insurance providers are going to be. The state, our legislators actually in each state get to pick, who do we want the insurance provider for the Medicaid population to be. Normally, the states will have protocols or laws around, we want at least 3 or 4 insurance providers for Medicaid. They don't want it to just be one group, because that one group would have a monopoly. They would get all of that federal funding, and there would be no incentive to provide good care, right? They're getting all the money, but where's the accountability to do a good job? So it actually helps states, if they have 3 or 4 providers, to say there's competition, you have to do a good job, right? So that people are picking you, so that you're getting that federal funding. So most states have at least 3, 4 different insurance providers. So you'll hear names like Humana, Aetna, CareSource. There's tons and tons of different ones. And not every single insurance provider is going to be in every state. It's just who the state picks. So the state will open it up. They'll say, hey, we're having a bid. If you want to provide Medicaid services in our state, then bid for it. And then we'll pick our top 3 or 4. So it's really interesting. I never knew that this is how this process worked until the last year. But the state ultimately decides who those insurance providers will be and how they will allocate that money to them. And then adults, the adults who qualify for Medicaid actually get to be the ones to pick which plan they want during open enrollment. So say I qualify for Medicaid, and I look at the 4 different groups in front of me, the 4 different insurance providers, and then I can decide I want to go with this group. So that, in a nutshell, is how it works. It's federal funding, comes down to the states kind of deciding who the insurance providers are, the different protocols and parameters that are set. So hopefully that all makes sense. So why does this matter? Why do we even care about any of this? The reality is, we know historically many trafficking victims and survivors have Medicaid if they have insurance at all. And so they are intersecting with the Medicaid insurance world a lot, because we know there are major physical health and mental health ramifications when someone has been repeatedly exploited. So they're accessing the system a lot, using their Medicaid a lot. And yet most health plans, especially if we're talking about Medicaid health plans, have 0 processes in place to identify if someone's being exploited or trafficked. They have never educated any of their caseworkers, case managers, staff, right? This is not on anyone's radar. They don't have any trafficking specific services within most of these health plans. So again, they have not created a service to say, okay, if this person identifies they're being trafficked, what are the unique needs that they have that we can provide services for? That's never been considered in any of these plans. And we know trafficking victims and survivors are a unique population. We can't just lump them in with other vulnerable populations and say they can just get treated like all the other substance users that have Medicaid, or unhoused population that qualifies for Medicaid. This is a completely separate, different, unique population that has unique needs that's going to be different from some of these other populations, even if there's intersections. And so that's what we're seeing, and Laura will expand on it, is that I think for decision makers who don't get it, they're like, they can just follow this plan for substance use, or they can follow that. When we're advocating for, no, they need their own unique services here through their insurance plan. So what we know as we look at this is, really, if we can utilize health plans correctly, they should be the funders for a lot of services that trafficking victims and survivors need. They should and really could be paying for residential services and inpatient detox and maybe unique types of therapy, if we're able to really connect the dots here. And I think this is important because as we're talking about funding services that survivors need, we know that other types of grants are going away or budgets are being cut, especially with things like VOCA. And so this may be a solution to some of that grant funding and money that is going away from nonprofits and service providers. So what we know with all of this complicated stuff, especially if we're talking about working with state legislators and the federal government and trying to say, hey, this is really important. Have we ever considered this population? How do we get them the specific services that they need? You have to prove that it's actually happening, right? We have to show that there's data. We have to show that trafficking victims actually have Medicaid, even though we all know that's true. And Laura was willing to take this on and do a research project around it. Last year, basically, CareSource, who is a huge Medicaid provider in multiple states, and they're really doing excellent work, they've been the ones who have really been pushing this, saying, hey, we care about this population. We want to do something about it. And Lisa Lucchese specifically has been the brainchild. She was going to present with us today, but she got sick. She said, all right, let's do a research study. Let's fund a research study. Let's prove that survivors and victims had Medicaid while they were being trafficked or afterwards, and what were the barriers that they had in accessing care? What are ways that we can do a better job? So Laura's going to go through all the details of the study, but we did do a research study with 125 survivors to look at issues around health insurance, what their needs were, access to care. And before the study was even published, we talked to lots of service providers around the United States, basically to say, what issues are you having in being able to get the needs met for the population you're working with? And of course, across the board, and most of you would probably say this too, is we have no crisis placement for kids or adults, right? We have someone who is ready to exit and there is nowhere for them to go before they go to a long-term residential program, right? Like that interim period, we need help there. Or we need detox facilities. Maybe we only have one or two in our state and all the beds are full all the time. Or we have survivors who want to do unique types of therapy, like equine therapy or art therapy, and Medicaid's not going to fund that. And so the only type of therapy that they qualify for is not really helpful. And so those are things we heard prior to doing the research. I'm going to pass this over to Laura, but as she did the research and looked at the trends, these things just became readily apparent. Take over, Laura.
There we go. Sorry. Thank you so much, Heidi. I have to find where the buttons are. And hello, everyone. And we're just very glad to be here. And you are our first audience where we're presenting this information. And so I wanted to thank A Safe Place and Aaliyah for inviting us to present. And I'd like this to be a conversation because we're really these are the high level findings right now. And we're just beginning to analyze all of the findings. And so I know all of you are experts in many ways. And so I hope this can be a conversation. And Heidi's going to do the slides for me, but please either raise your hand or just, we can call on you if we see that you have something to say. Let me just set the background for this by saying, again, just in financial disclosure, CareSource and Global Centurion, which is my organization, were the sponsors and funders of this survey. It's small, and so it can't really be for study purposes. We can't generalize to the larger population, but I do think that it opens a path and it opens the conversation, and people can take it from here. I think we do need a larger study on this. And I will say that, like Heidi, I really wasn't thinking about Medicaid at all until I was talking to a survivor who was trying to help us draft and pass a law in Virginia on health and human trafficking. We're attempting to get legislators in all 50 states to draft and pass laws that will require health providers to be trained in human trafficking in order to renew their license. And we want it to be mandatory because oftentimes those who aren't interested or don't think they need it are the ones who need it most. And so there are 7 states that have done this, and we were in Virginia, where I live, we were trying to get this new mandatory law passed. And I was working with several survivors, and Medicaid kept coming up, and they kept saying I was just denied for this service. I was denied for that. I can't get this. I can't get that. And so I was hearing this kind of in the back of my mind. And then Lisa and Heidi contacted me. And so I was already aware from the work that I was doing on health and human trafficking that this was an issue, but really didn't know much about it. So we decided we would do a retrospective survey of survivors of trafficking. This is a time-honored method of collecting data from those with lived experience. We used the definition of trafficking from the TVPA, the Trafficking Victims Protection Act. So we eliminated anybody who was not already identified as a victim or survivor of trafficking. We included sex trafficking and labor trafficking. We included males and females. The study was only 18 years of age or older. And we did apply for and get an IRB, which is a review to make sure that we had all of the pieces in place to protect the survivors because they're considered human subjects. And so we haven't had an IRB in place. Next slide. And so we set up the methodology in advance, and this was all part of getting that IRB approval. We had an advisory board of 5 survivors, 5 paid survivors, and we used reverse snowball method to identify participants. And through that reverse snowball method, we identified 25 participants. There were actually many more than that were identified in the end, but we only had time to include this first 125. We had a structured online format. So unlike other surveys that I've designed and participated in, usually I do them in focus groups and there's a lot of time to talk with survivors, and there's 7 or 8, and we get a lot of background information. This was a short 20-minute survey that survivors signed up for online, and then once they hit the button to submit, they were paid online $50 in a gift card for the time that they took to fill out the form. And next slide. And as Heidi said, we covered a lot of ground in that 20 minutes. We asked a lot of basic demographic questions that had not been asked in many other health surveys: age and gender and race and education and sexual orientation and many other, and I don't have the stats here, it would take too much time, but anybody who wants those, we can send the report to you that has all of those. And then we asked about their top 5 physical health issues, their top 5 mental health issues, what their health insurance status was, obstacles to obtaining the health care that they needed, challenges in the insurance process. So this was really all about the health care they needed and their ability to obtain that health care with insurance coverage. And then recommendations for improving access to healthcare services, which is something else that hasn't been done before. But I hope more and more researchers are including a section in their surveys where they can ask survivors across the board for their recommendations, because that lived experience is critical. And so they helped us shape the recommendations that we're making. And so this will just go through really quickly the top line, as I said, findings. In addition to the other demographics, among the 125 participants, a large plurality was, I'll just give you some background on the age, that about 43% were between the ages of 35 and 44, because this is a retrospective study. And over half of them, 57%, had not gotten a college degree. About 10% hadn't finished high school. About 4% finished high school by getting their GED. And so this is all something that happened afterwards. We had 66% were white and 22% were African American, and 7.8 or 8% were Asian, and were Native American and 6% were Hispanic. So it was a pretty good division between those. And then we wanted to ask so about sex trafficking and labor trafficking, and nearly 96% were sex trafficking survivors. 17% had experienced labor trafficking or had also experienced, so almost a fifth had experienced labor trafficking. And I think we had 7% were males. For a first survey on this subject, I thought that the demographics were good. And then this one we wanted to show because it just corroborates what we've heard and found in many other studies, that the age when first trafficked was very young. Almost 25% were 14 years old or younger when they were trafficked. 25% were 15 to 17. So that means almost half were minors, were under the age of 18 when they were first trafficked. And then 34% were, or 35% were 18 to 25, so still youth. And then you see 10% and 4% or 5% as you get older. So the young and the very young are really vulnerable and so all our efforts that are aimed at stopping child trafficking are very important. And then a type of insurance that they had. 47 or maybe 48% said that they had no insurance coverage. Not surprising when you're out on the street. But what was surprising was that 40% had insurance while they were being trafficked. And in fact, a couple of survivors wrote in the comments, because in every question we had a place where they could comment or other, and a couple of them wrote in the comments section, my trafficker took full advantage of government programs of various sorts, housing programs and Medicaid and other. And so you can see here that either, for the most part, they either had no health insurance or they had Medicaid. And then all the others are very small percentages, private health insurance and care and so on and so forth, while they were being trafficked. And then this question, I need to go back because it looks rather vague, but it wasn't that they were denied coverage. In other words, that they didn't have Medicaid. It was that once they were in, they were able to get most of the services that they wanted. And so 3/4 said that they were not denied coverage, and about a quarter said that they were denied coverage. And we need to do more analysis of this and what this means. Go ahead. And this, we're going to redo this chart. Unfortunately, it was pulled right from the raw stats. But if you combine these, you can see that the top 4 physical health problems were neurological. So they were everything from sleep disturbances and fatigue and headaches and migraines and memory problems and insomnia and nerve damage. Those are all categorized as neurological kind of issues. And then next was dental. And then next was sexual health, which includes gynecological, reproductive, and procreative issues. That was among the top 4. And then finally, injuries from violence perpetrated either by the trafficker or by the buyer. So those were the physical health issues. And then here, mental health concerns, 89, almost 90% of victims reported having PTSD. And so this is the stat we're using because that's a kind of a grouping that oftentimes includes all these other things. And then you can see they've checked anxiety disorders, panic disorders, and phobias as the next largest category of health concerns, depression, flashbacks, trust issues, substance related and addictive order issues, and then it goes down from there, bipolar, suicidal ideation, and dissociative disorders, and so on and so forth. But this is a huge finding, and I think there's more and more. Again, this corroborates what many of the service providers are saying about the need for more focus on mental health concerns. And I'm sure many of you have heard survivors say that the physical health issues, you heal from those, but that the mental health issues often go on for decades. And so it's an important area to stress. Next. And here we begin to ask about the therapeutic services. And again, top on the list was the need for some kind of therapist, psychologist, or psychotherapy, behavioral therapy, medical health treatment, substance use treatment, and then general health practitioner. It comes a little bit below the 50%. And underneath that, all these therapies that are either not offered or are very hard to qualify for if you're a trafficking victim, and particularly if you are a trafficking victim and you don't have a comorbidity, as Heidi was mentioning. And in the comments section, so many survivors wrote, "I'm done with talk therapy. It doesn't help. It just goes over and over the same old issues. And it's almost like reopening a wound over and over again. I need something that's going to help me live my life today and in the future and not keep revisiting the past." And so that was an indicator also that not that we don't want talk therapy or the traditional talk therapy, but that we need these other therapies to help jumpstart the new life that survivors are looking to, that healing that they're looking to do. And Lisa can talk to this much better than I can, but she's been involved at CareSource in getting these new kinds of the therapies that survivors are requesting, and they include art therapy and animal assisted therapy and equine therapy and occupational therapy and the it should say EMDR, eye movement desensitization therapy. All of those are therapies that are being requested, and that's where I think a lot of the coverage denial is going on. Next. Then we also asked about life services that they needed, and we offered a list, and these were the 5 that came up most often, and all of them you can see above 50%. Everyone needs a way of communicating, a way of being able to link to the outside world. And so cell phones are huge. And having been or being a subject matter expert for the Department of Defense, we had a lot of labor trafficking issues, and that was the biggest thing that came up, was that they were unable to call or locate or get to family members and others that might be able to help them if they didn't have some kind of just basic cell or smartphone. And so this is really critical. Educational opportunities also very important. And then you see shelter and transportation and job assistance. And I'll just say that in another study I'm doing in Detroit that looked at the barriers to healthcare, the 2 top barriers to getting healthcare for trafficking victims and survivors were transportation. They couldn't get to and from the doctor. And the other one was they didn't have documentation, ID, or something that could get them in the door. And so I think that these are also really important for us to understand. They don't seem to be specifically related to healthcare, and yet they are in many ways, and into healing and recovery. Yeah. And then here is what Heidi was referencing before, that in order to get the kind of health care they needed, so they identified top as victims and survivors of trafficking. But in order to get the health care they needed, they often had to identify as something else. They had to identify as a survivor of sexual abuse, as an individual experiencing homelessness, as an individual experiencing substance use disorder, as disabled, or even as transitioning out of incarceration. Why? Because Medicaid has specialized programs for those below that top line. They have with special criteria, And so those programs are being offered by Medicaid providers, and survivors are offering up basically this other comorbidity, which is fine in some ways. At least they're getting the coverage, but not good in other ways, because it means that, as Heidi said, we're missing those survivors we're missing what's really happening to them. Why were they needing housing? The real reason was because they were a victim of trafficking, but that isn't a specialized category. And so they weren't able to really find a way into Medicaid with that categorization. And then obstacles to care. Here again, the survivors themselves reported that the obstacles were that there's a lack of specialized care for trafficking survivors, that there's limited coverage for mental health services. You probably all know this, that there are high out-of-pocket costs for medications and treatments. And then there were some other interesting findings. Survivors said, I felt I received lower quality care or treatment due to perceptions about being trafficked or involvement in commercial sex. And the process for obtaining healthcare coverage was confusing or complicated. There's an inadequate network of healthcare providers wherever they lived, and limited coverage for physical health services. And some of these are repeating. Difficulty in accessing Medicaid coverage in a way is similar to the process for healthcare coverage being confusing. And then their coverage was denied, was the last one. And then finally, we asked survivors about what their recommendations were, and not surprisingly, they wanted increased survivor-specific services, trauma-informed counseling and care, case management, treatment for less common gynecological issues that result from sex trafficking and sometimes labor trafficking, ensuring that healthcare providers are informed on the needs of human trafficking survivors and victims. And so one thing we could ask the Medicaid providers, I think there are 18 of them across the US, they're all fairly big, is whether they're training their staff, first of all, and then whether they're training all their healthcare providers who are providers that take Medicaid on health and human trafficking issues. And then again, they wanted trauma-informed staff or providing training on a trauma-informed approach to healthcare. They wanted the care network of services to enable survivors to get holistic care expanded. And they also wanted coordinated service providers. And this is probably something that occurs in other arenas too, but a simplified process for eligibility and enrollment. When you're sick, particularly when you're a victim of trafficking or when you're just exiting trafficking and you have physical and mental health issues, the idea of going through all these processes, unless you have somebody to help guide you through them, it's too much for people. And increased awareness of available services and promoting cultural competency for Medicaid providers to better understand and respond to the needs of survivors from diverse backgrounds. That's huge. And this is my last slide, basically, the challenges and the way forward. And I'm summarizing in some ways what we went into this study with, a hypothesis that the denial of coverage for residential and other important treatments for trafficking victims and survivors, unless comorbidities were identified, lack of specialized services that work for trafficking victims and survivors, and here I said, i.e. less talk therapy and more of the other kinds of specialized services, a lack of knowledge about trafficking and trauma-informed care and other approaches key to successful treatment of trafficking victims and survivors. And that leads to this need for training of Medicaid providers and healthcare providers who take Medicaid. And then finally, a need for understanding the new ICD-10 codes, electronic record keeping, reporting, mandatory reporting, and other issues related to health and human trafficking. And somebody's got a poll here. Maybe it's a safe place that they'd like everyone to participate in, and we'd like to open it up to questions and have a back and forth because as I said, this was a small study. It's the beginning of the conversation, and I'm sure you all have expertise and you have information that could help guide us. One of the things that we'd like to do is to go to HHS and CMS, the Centers for Medicaid and Medicare services, and to ask them for some kind of working group, some kind of technical working group where we could bring the best minds together, survivors, service providers, Medicaid providers like CareSource and others, subject matter experts on trafficking, healthcare providers, and others to brainstorm about how we can get from where we are right now to where we need to be. And in order to do that, we have a lot of convincing to do. And so we'd like to form a partnership with all of you and figure out a way to encourage and urge HHS and especially the Office of Trafficking in Persons, because we need the political will of the Office of Trafficking in Persons in order to make this happen. So that's where we are right now. And you all may have other suggestions. Definitely interested in the conversation on the way forward. So thank you. Thank you for giving us the opportunity to present. And Aaliyah, right? Aaliyah or Alia?
Aaliyah, yes. Yeah, Aaliyah.
So thank you so much for putting this together. We appreciate it and look forward to continuing partnership.
Awesome. So do we. And we're really excited about the findings and the potentials here as well. And so I'm going to open up for discussion a little bit. And so if people have been a part of these webinars and have been coming for the last 2 years, you know that typically we ask you to put everything in the Q&A and we don't unmute. We're going to do things a little bit different this time. And I will unmute people one at a time to ask questions. I do want to start with the questions that have been brought up already and the questions that are in that question and answer. And so Heidi, do you have the ability to see the questions that are in the Q&A portion? Awesome. And then I also want to just tell people because I know there's a huge desire for the report that you guys completed. And so I want to let everyone know you will receive a copy of this recording. Anyone who registered for the webinar will receive a copy of this recording. And when they are completed, they're making some final tweaks on the report. When that's completed, I'll ensure that you receive that as well. So the fact that you're here means that you will receive a copy of the report. Don't worry too much about that. So I'll let you answer the questions in the Q&A. And then as people raise their hands, we'll unmute one at a time.
Okay, sounds great. Thank you. And I've seen lots of comments in the chat as well about wanting copies of the slides. I'm completely fine with it. It's most of it's Laura's content. I will defer to you, Laura, but I'm fine with people having copies of the slides.
Yeah, can I just say that we have a page right now that has the high-level findings in a much more understandable way, and we're regrouping those 2 or 3 slides that have just the raw data so that all the neurological conditions are together, all the gynecological, reproductive, and procreative are together. And once that's done, then we can I'd love to send that slide out more than this one. We just couldn't make that happen, but we can definitely, right after this, we can send the high-level findings out so that everybody has them. And we think that the report itself will be done probably next week. And then after that, we can send that to Aaliyah and she can get it out to everybody.
Thank you, Laura. Okay, I'm going to dive into the questions. Some of them are specific to you, Laura, but the first one says, is there any coverage in any plans for a registered dietitian to address eating disorders? So I will answer this to the best of my ability, but anyone else, please feel free to chime in. I would say I don't know the answer, because every single plan is different. So each Medicaid plan is going to be different in what they will cover. And I don't know every single thing that people qualify in each plan. There's just too many of them. So I would say the best way to find out that information is, if you're working with a client, is to call their health plan and say, hey, do you guys cover this? And get the answer there. It is so complicated. There's no easy way. You can't just Google and figure out who qualifies for certain things. Usually it means spending a lot of time on the phone trying to figure things out, and it's frustrating. The system is so hard to navigate. So I don't have an easy answer to that question. I'd say your best bet is calling the actual health plan to find out. But if you want to chime in on that, Laura, please feel free to.
We asked about eating disorders, and the other thing that we'll include, and you're all reminding me, is the actual survey, so that you can see what that survey looked like. And we did get responses, and we know there's a link between trafficking and eating disorders. And my first instinct is no, because that was something I missed in my first study. There were a couple things I missed. I didn't ask about eating disorders. I didn't ask about cutting and self-harm. And so in just the last 10 years since my health and human trafficking study came out, some of these additional issues are emerging, and that's a really important one. And I remember survivors saying to me in focus groups, when I got out of trafficking, the most important things were eating and sleeping, because I hadn't been able to sleep and I was never able to eat properly. And because their lives were controlled by somebody else. And so that's an excellent question. And I'll see if I can go back and tabulate that data for you, just so you have it.
That's great. Okay, Laura, this is specific to you. Was the survey in English and Spanish?
Unfortunately, no. It was on the health and human trafficking study. I did have a Spanish translation and we had Spanish speaking focus groups, but on this one, there was a 3-month period where we did the study. We had to identify the participants. And so maybe another thing that I need to say is 18 or over English speaking. So there are whole other populations that we need to reach, and I realize that.
Sure. Okay, here's another question for you. This is a great question that I had not even thought about. Was the study done with survivors in states where there's Medicaid expansion, or both? I imagine access issues will be worse with adult survivors who are in states without Medicaid expansion. I'm also curious if your sample included individuals who are foreign nationals who may only have limited access to Medicaid. Great question.
Yeah. As I said, this was 120 participants, and they were located through this reverse snowball method, which is the preferred method for reaching participants. So we didn't go out and say, hi, survivor, would you like to take this? We asked survivors to identify survivors who identified other survivors who identified other survivors. That's that snowball method. And again, Heidi was just asking about a comparison between the main health study that I did. And in that one, we went to 22 cities. And we were on the ground in 22 different cities and 20 states. And we wanted to do that because we wanted to make sure that we had that somebody couldn't say that doesn't happen here. It only happens in Texas, or it only happens in Florida. Here, we were relying on survivors to locate other survivors, and so we were unable to. I think we have the state information or the geographic information about where they're living now, but not about where they were trafficked and when and all of that kind of thing. We just don't have that detail of information so that we could know what the Medicaid plan was during the time they were trafficked.
Okay, next question. Have pharma companies for gynecological pharmaceuticals been approached to assist in the education of healthcare providers? Pharma reps are typically in doctors' offices multiple times a month educating on their products. Great point. I will say, from a healthcare perspective, no one is educating anyone about any of this. It's very far and few between. And so my guess would be this is not even on a pharma rep's radar. I think some of them might be interested if they learned about it to provide this education. That's a great idea. They already have their foot in the door but I would say I've never heard of that. And I would say most healthcare workers, there's a disconnect. They are not aware, but Laura, please feel free to chime in.
Oh my gosh, I'm gonna, whoever this anonymous attendee is, let me just say, let's educate the pharma companies
Great idea.
first,
Yeah.
because all of their medications and also all the medical technology, all that's a whole new area of first. And if we could bring the pharma companies up to speed on trafficking, that would be a huge accomplishment. And then they could go in and
Yeah.
educate. And it's a great idea. And just like this idea on Medicaid, it's something I had never even thought of before. So
Same.
whoever this is, you're on the cutting edge, and love to
Yeah.
work with you on this if there's a way to do it.
Agreed. That's a great idea.
It is.
Laura, do you plan on doing another larger study, and would you want help providing data?
Yes, this is the other part of this that I would like HHS to get involved in, the Department of Health and Human Services at the federal level. This is a federal issue first and foremost. And it needs to, we need a study that goes across the nation, and then it needs to inform the not just the work at the Office of on Trafficking in Persons in HHS, but also so that's on the human services side. I don't know if following. So there's the reason it's called Health and Human Services, because there's a health side and a human services side. And the Centers for Medicaid and Medicare are on the health side, and the Office on Trafficking is on the human services side. And there are, I think, two undersecretaries that feed up to the Secretary of State. And again, figuring out how to get that political will. The reason that the Trafficking Victims Protection Act was so effective is because the Congress passed a law, and it has a president's interagency task force on trafficking, which it's a cabinet level task force, and they meet every year. And the political will streams down from the president to the secretaries of each of the agencies that play a vital role in trafficking, in combating trafficking, and then down from there into their agencies. And what we've got right now is a couple of mid-level people trying to push upward, and that's what we need. So the short answer is yes, we need a national study, and it has to be done. I'd like to do it with focus groups, because you find out much more about the context of the trafficking and the context of the healthcare when you do it that way. And that would require some investment of time and
Yep.
resources. And CareSource invested a very small amount of money. It was huge for them, I will say, but it's a small amount of money, and this was all we could do with that money. But any of you who'd like to sign a list, and Aaliyah can send it to us or can coordinate, and we'd like to send a letter to AHHS and to the Office of Trafficking saying this is what we suggest. And I'm happy to compose a draft, and everybody can add to it. And I think that's the way to try to get that political will, which would include a national study and a technical working group and some suggested criteria for HHS to expand the services to this specialized population. Those are the three recommendations we have so far.
Yep.
And Laura, if you did compose that letter, we would happily send that out to everyone that attended, along with our TSET group, our policy group as well.
Okay. So then that's the way we'll do it. We'll draft a letter, we'll send it to you, and you could send it out, and we could get that signed and get it over. I'm in some preliminary discussions with the people at OTIP, with Catherine Chan and her prevention coordinator, Joanna Mateo. But the questions they're asking right now are ones that it's chicken and egg. We can't answer them until we have the study in the technical working group, and they want them answered before the study in the technical working group, like that kind of thing. But we'll get there.
Yeah. Okay, next question. If the survivor's moving states for care, which state do they apply for Medicaid in? The state they came from or where they're going? They need to apply for the state where they're going to be a resident. I don't know if you want to add anything to that, Laura.
I don't know enough about it. I assume this means after they're out. Wherever you are, the Medicaid is state generated. The funds are federal, but the
Correct.
Medicaid itself is state generated. So wherever you're living, that's where you apply.
Yep, exactly. Have you tried to work with Chaplain Hall Research, the think tank out of University of Chicago?
No, happy for any partnerships or even leadership. I am not a healthcare provider, and nor am I a Medicaid provider, and there may be others who would be better positioned to do the next steps on this, and happy to hand over what we've done so far and let people take it from there, or to partner.
Has there been discussion about the safety of the offices for these resources? It's been known as a recruiting ground for exploiters.
Medicaid? What's been Medicaid?
Or
No.
more of the resources like detox, things like that. I'm not quite sure.
I see. We included safety plans in our in the survey, asking about whether those were a need, but yeah, I don't know enough about that to Tika, if you can give me more information on that. I certainly have heard that there are issues in shelters and that we're on the in the foothills of consciousness on the front end of figuring out how to protect those who are in shelters from recruiters or from traffickers sending recruiters in. So glad to have more discussion about that, and glad to mention that as a cautionary as we write up the final report.
Yeah. Okay, last question. I know we're about at time. One says, we serve minors that have had issues getting their Medicaid transferred to our state where services are being provided. They have denied, saying they aren't a permanent resident or their parents don't live here. Any suggestions or thoughts? I have seen the same thing. I'm based out of Missouri. That's difficult with minors. I don't have a great solution, but I've definitely seen that happen. That has happened.
Okay, but this is the kind of thing that if you had a specialized set of criteria
Yeah,
that came from the Center for Medicaid and Medicare, that it could address just those questions, and we could have a special way of handling that. And I know that even for adults, oftentimes now they need or want to be transferred out of state to a shelter that is not near where their trafficker is. And that permanent residency kind of thing, if that's a sticking point, that's something that we need to address. And thank you for that. And we're drawing up a list of the problems we have right now for HHS, to tell them this is why you should have a technical working group. And I can add that to this.
I know we're at time, Alia, so I don't know if you want us to answer any more questions or wrap up, but thank you guys so much for these amazing questions and discussion.
Yeah, I think looking at Ashley's question was very similar to Amber's question right beforehand. And I know, Ashley, we see that a lot as well. And I think it's just important to note that because they're county, Medicaid's hosted through county or through state, we're going to have differing experiences. I know, Ashley, even though we are in California, the difficulties that we're seeing is very different than the difficulties they're seeing in Texas. And honestly, like Texas is very difficult to get survivors on Medicaid quickly unless they have some kind of comorbidity. So then I just want to thank you, Heidi and Laura, for facilitating this and for sharing this information with us.
Thank you. Thanks for having us.
Thank you so much. Bye-bye now.